Will you give us an overview of those specific cancers?
Sure. Thank you, Krista. Thank you for having us, and thank you everyone for logging in tonight to listen to this conversation about gynecologic cancers. So by definition, gynecologic cancers are cancers that involve the GYN tract, namely ovarian cancer, fallopian tube cancer, also endometrial cancer, cervical cancer, vaginal and vulvar cancers. These are the big tumors that could involve the GYN tract. There are some other rare entities, but these are the most common ones that everyone hears about.
Thank you for clarifying that. And what are some common treatments for those cancers?
So treatments can range depending on the cancer and the type and the stage of the cancer. But in general, if you want to put them in large categories, one can talk about surgery. Surgery could be a very important treatment modality for some of these cancers. Chemotherapy is another modality. Radiation is another treatment option for certain cancers. Immunotherapy now is something new that we're using. We separate that from chemotherapy because it works in a different way. The treatment can involve either one of these approaches in combination or separately. And obviously it depends, again, as I said, on the type of cancer and the stage of the disease.
Okay. And as Dr. Schumann mentioned, with those treatments, surgery, chemo, radiation, and immunotherapies, Dr. Canlis, I'm going to direct this next question to you. After receiving their diagnosis and treatments, and that begins, what are some ways patients can prepare themselves for the best possible outcome and prognosis?
Yes, and traditionally what we have done is patients during or after their chemotherapy, surgery, radiation, they sustain some sort of disability, neuropathy, fatigue, deconditioning, and then they have difficulty functioning at home or at work or in their community. And so we begin the rehabilitation process through a combination of physical, occupational therapy, often analyzing for depression or difficulty with anxiety and adjustments. But as we've grown that portion of rehabilitation, we're trying to look also at prehabilitation, where we try to prepare patients as much as possible in preparation for surgery or other cancer treatments. And then that's through attention to diet, exercise, planning their home environment, any supportive assistance they may need at home as they transition back home, and then planning for stages of work. So with our department, we're going to hope to interview patients earlier, get to them earlier, and plan for these things. So
I love that because like with anything, a marathon or any type of competition, people train and they prepare themselves. So I love the thought of the pre-rehabilitation.
If I may say, we work very closely with Dr. Canlis with our patients in trying to prepare them for any of the treatments. And we've been talking and growing the program of rehab medicine for our patients in anticipation for major events or treatments such as big surgery or chemotherapy, and how can we make the patients or try to make the patients go through these treatments with the least side effects possible. So the treatments can have an impact, but can we prevent that impact or side effect from happening by having Dr. Canlis evaluate the patients and make an intervention beforehand? And we've seen that this is very, very valuable for our patients.
So is that something, this is a little bit off script, but is that something that they need to be referred to do, and how does that work with their insurance? And that might be a question that you guys can't answer, that maybe an insurance department might have the best answer for that.
Usually we make a referral when we see a patient that is expecting a certain intervention, a certain treatment that is going to impact them, and we feel that we can intervene by preparing them for that physically, nutritionally, then we reach out to Dr. Canlis and we make a referral so that we can minimize that impact or that side effect ahead of time, especially if we have the time to do that. If not, then we make a referral to Dr. Canlas after the treatment is done. Let's say after a big debulking type of surgery for ovarian cancer, the patients might need some rehab and strengthening, then we will make a referral to see Dr. Canlas afterwards.
Perfect.
And the insurance companies usually allow that.
Great, thank you for that information.
Sure.
So mental health, we all know, is just as important as your physical health, but it's often pushed aside when patients get that initial treatment, or I'm sorry, initial diagnosis. So, Dr. Brown, what do you tell your patients when they come in after they've started treatments or they're finishing treatments? What are some things that you suggest to them?
I think I would start, first of all, that being part of a team, I have to say already, I love the referrals when someone's looking at the fact that you've got the body and the mind. You know, it's not a floating head, it got connected, and the importance of looking at how the stress of the mind is affecting what's going on in terms of how well they do. And I've been very fortunate to be part of their referrals when they have some patients. And one of the first things I have to do when a patient gets referred to me from something that is so obviously physical is explain to them that I'm part of a team and that we're looking at the big picture, and not letting them think that, oh, great, I got shuttled over here to something for depression and anxiety. It's bigger than that. It's truly looking at what they can control themselves when everything's out of control to kind of cope with what's going on. And one of the things that I look at right away is where's their energy level. I mean, this is, by the time they come to my office, they've already gone through some very emotionally draining conversations. And if they're far along in their treatment, it's physically draining as well. So one of the things I look at is that person, when they're talking, I can hear it and they can identify where do they find that they get their energy. And if I am someone who is a little quieter, a little more introverted, a little more of a thinker, then I need time alone to get energy. So you take an introverted person and you throw them into a world where people are talking to them and touching them and doing things, and they don't get a break. They don't get to go away by themselves and get that time. They will have very little energy thrown into that environment. If someone has a little bit of a tendency to get energy from movement or a lot of people or activity, they are enjoying in some way that they're getting a chance to talk and ask and have people come by to visit them. So if they end up being isolated in some way because they have in recovery and people have quit coming by, they're giving them time, then they don't have energy because they're not plugged into their source of energy. So it's when they enter into my office, where are they? Are they just diagnosed? Are they somewhere in the process? Are they finishing all of their chemo and then they're still anxious or depressed at that point and then they're coming in? Because they get lost. They lose their identity to some degree in this whole process. They have to re-identify who they are, what's their role in the family, the whole picture. I have the luxury of spending an hour with them. So I can hear their stories and kind of see who is shifting, who's shifting into place, whether they can give something up. But it goes down to stress, and it goes into how do you recover energy when you're under that much stress. And one of the other things is that this is a very scary thing to most of them. So without meaning to, they're going into the future a little bit. And with going into the future comes worry. And then with worry, I can kind of scare myself more, and I can turn that into anxiety. Or they go into the past and they're wondering what was and what should have been caught and what was their life before. And then they can go into a sense of hopelessness or helplessness. So now we have depression. So kind of pointing out that as you time travel, you're bringing anxiety or depression in, and teaching them really to kind of try to stay right where you are right now. There was nothing right now that you can do about the future, and you can't undo that. So it truly is bringing them into this is where you can heal the best. and try not to go too much either way. People come in and do the same thing. They start talking to them about what's it going to be, how's it going to change, what's happening with your family. So even if you're centered, you can be pulled out of that very quickly. So a lot of it is just kind of looking at bringing in and making that almost common sense, that they can use the time where they are at home or in even treatments to kind of bring themselves back in. And then the length of it with the fear of the recurrence and stuff, I know we'll talk about that, but I kind of try to fill in, and they bring questions in and some of their fears and anxieties, and reminding them they have a voice, and to be sure to talk to their physicians about their fears, and not to consider medication to help in the behavioral medicine field as wimping out or taking the weak side, because they have a sense to put, you'll agree to anything physical medicine, but you are hesitant for some reason to see if there's medicine to help you cope with it as well. So giving them permission to see that, if you wouldn't hesitate to take insulin as a diabetic or chemo to help you with that, why would you be so hesitant to try to take some behavioral medicine to help you with anxiety and depression? So trying to get rid of the shame of that and the factor of that. So that's where I try to fill in and be part of what their world is with the patient.
And those are very important parts. And thank you for bringing those to a lot of people's attention, because many of those things are overlooked. I'm sorry, Dr. Canlis, I didn't mean to interrupt. Go ahead.
No, it just, we've shared several patients, in the past years, and a lot of that collaboration really helps push through barriers in the physical therapy setting as well. Because a lot of times the physical therapist is hitting barriers, but the emotional component and sometimes pain can be a manifestation of, anxiety or depression. So really patients can excel and really achieve a lot of goals, strength-wise and conditioning-wise and pain-wise, even in the physical therapy setting, whenever their emotional needs are being attended to as well. So
I cannot emphasize that more as well. And there are studies actually that have shown that patients that have the mental health and the mental resilience and the strength usually do better on the same treatment than patients that do not have that. So that's why it's instrumental to have somebody like Dr. Brown be available for our patients to direct them in the right mental direction that can help the outcomes be much better.
And I love that you said that you have a voice with your medical team, because a lot of times we'll talk with patients and their families, and we'll say, did you tell your doctor that? And we're like, no. So it's important for them to know that they have a voice too. They don't have to just go in and listen and then do what's suggested, that they can ask questions and that you guys are there for them and open to that. So Dr. Brown, I'm going to pick on you a little bit. I'm going to send you the next question too. A cancer diagnosis affects the whole family, not just the one diagnosed. They lose their roles change. So what can family members do to also cope with their own stress and anxieties regarding a family member's diagnosis, or maybe they're a caregiver? And that's a new role. So how do family members cope with that?
The family members, that's a bigger ball of wax, because it depends on who are their family members. And again, I get the luxury of time with them. So are they married or are they not? Do they have a good relationship or do they not with a spouse or a partner? Do they have teenagers or do they have grade school? What kind of relationship do they have? Whatever they've had before, now we put it into a very stressful situation. And so if they had problems, they may become more, or they may try to fix them. But the caregivers or the family members, they get lost as well. Do you help? Do you not help? They don't know. They're waiting. If you were the mother and your role was to kind of coordinate everything, it's like, who's going to pick that up? And so unfortunately, a lot of times they're waiting for permission from the one diagnosed with cancer to do things, because they don't want to take something away from them. And the person with cancer often is just kind of wishing somebody would pick it up and do it. So it depends on, it comes down to clarity. It comes down to what is it that you really want, and being able to communicate that to your family members. But the family members, you know, they go through their own stages. They don't want to believe it, or they're frightened. They get into kind of a fight or flight mode where, you know, they just either kind of want to run and bolt, or they kind of want to hover. So it depends on their role as to that answer. So it's kind of hard for me to give a more specific. Other than that, they get absolutely worn out trying to figure out. If you have teenagers, sometimes they just get mad. You know, teenagers really are about figuring out who they are, and they're coming from their view. So this cancer is kind of inconvenient. You were supposed to be here for my senior year, you know, but it sounds horrible to say that. So they end up just appearing snippy or isolating themselves because they don't know what to do, and they don't know how to help. And so then people that have cancer are getting their feelings hurt because the teenagers pulled away instead of coming toward them. Little kids are simpler. They just give them something and they're happy to do it. They're kind of able to pick up on your feelings. So sometimes they're the ones to turn into the room because they kind of are very sensitive to what you're discharging, and they can kind of crawl into your lap or entertain you based on kind of the signals. It's the spouse or the partner or the mothers of the ones with diagnosis. Those are the ones that I have to kind of look at more fluidly to give them the skills to calm them down, because they are going to do worst case scenario planning even more so than the person with the cancer. The person with cancer, after a while, they're kind of the ones that are the most calm about it, but the people around them are often like, I don't know what to do. I always did this. And then once you get past the treatment and you go into recovery, after a while, everybody tries to shift back to their roles. And sometimes the ones that have taken on a role don't want to give it back. And so then you have dynamics afterwards. So it's a process that goes from months to a year of recovery oftentimes. So that's kind of a generic answer, but it's so specific to the individuals. It's just kind of meeting that whole fight or flight reaction at different times when different people have them.
Yeah. Again, very good points, and things that many people don't consider before their diagnosis or even after they've been diagnosed. So thank you for pointing those out again. It's very important. Do you guys have anything that you wanted to add to that? Okay, I'm going to just send a reminder out to the participants to type your questions into the chat so that we'll have those to answer during Q&A. Okay, we've discussed the different types of treatment and the importance of physical and mental health. Dr. Schumann, are all patients treated with surgery, chemotherapy, and or radiation immunotherapy? You kind of alluded to that earlier. Can you go over it again for the participants that are just joining us?
Sure. No, not everybody is treated with all these modalities. It depends on the type of cancer, and depends on the stage on when it is detected. Sometimes all we need is surgery and then observation afterwards if it's early and there's a low risk for recurrence. However, sometimes we might need to add to that. It could be chemotherapy, it could be radiation, depending on the type of cancer. Sometimes we use other modalities, like you mentioned, immunotherapy, but not everybody is going to need all these modalities. It depends on what we are treating and the disease, because these are different disease entities and they behave differently. Although they are gynecologic cancers, they are very different in the way we treat them. Each one of them you can think of as a separate, different cancer. Like, we know that not all cancers are the same, and there are hundreds of not thousands of different types of cancers, and they are not all going to respond to the same exact treatment modality. And the more we are learning about these cancers, the more we're finding what works specifically for this type or this subtype in this specific situation.
Great. Okay, thank you. And well, you're so good. You answered my next question.
Okay.
So you did great.
All right. Thank you.
A cancer diagnosis is already challenging, to say the least. And then there are also those pesky side effects from treatment. And this is what we hear about a lot. What are the most common side effects from these types of cancers? And Dr. Canlis, how are some ways that you help patients cope with those?
So when patients come to my clinic, I often will read through their notes and see what they've gone through in terms of treatment and where they are in their phases of treatment. And then take a functional history on what they're doing now, what their prior level of function was. Were they working? Were they at home? Were they able-bodied to begin with, or were they already sort of deconditioned at baseline? And then we try to set goals based on those things, current function and then prior function. Is the goal to eventually be active again at a community level, or just kind of function at home and their role there? And so then we go into more of, well, what makes sense in terms of getting you there? Can you do a therapy program? What kinds of therapy would make sense? Would it be at home first and then transition to an outpatient? Are you declining so fast that maybe we need to do inpatient first and then transition to an outpatient? So there's different levels of therapy that need to be coordinated. And with those go prescriptions, and then we have to be accurate about the diagnosis. A lot of patients are complaining about fatigue, neuropathy in the form of either numbness and tingling, and sometimes it can be painful in the lower extremities, especially weakness, weight loss, fogginess, those kinds of things. And a lot of times balance and falls is what brings a patient into my office. So I'm doing a neuro exam, I'm doing a musculoskeletal exam, I'm looking at their prior history, and then we're formulating a treatment plan and any equipment that they might need, whether it's a walker or a cane or a brace on the ankle. And then also trying to address their pain, is the pain from neuropathy, and then we go into that workup and treatment. Is the pain from exacerbated orthopedic issues because of immobility? We also evaluate that and work that up. And the more accurate I can be with my assessment about a patient, the more information I can really empower the therapist with, so that they're really maximizing their time in therapy and their outcomes are better. And it's always individualized and goal-oriented, and again, trying to make sense with their environment, with geography. If they're really far from a hospital and they live remotely, what makes sense for them? Transportation is often an issue. If they're close to campus here at the Deaconess campus, then that's good. Our team is very coordinated. We talk frequently. So that's sort of the initial approach, and then subsequent follow-ups. Are you improving? If you're improving, then that's good. If you're declining, then we really need to move a little bit quicker. Be a little bit more frequent with our follow-ups and make sure we're not overseeing something. And often I'll reach out to Dr. Schumann's team if I have a concern, and they're very quick to respond. It's been a very collaborative effort. I think patients have really appreciated it. And I think their quality of life has improved. In our discussions with therapy just recently, quality of life sometimes can improve by 30%.
So what is physical medicine and rehabilitation, the PM&R, and how is that beneficial, and is that here local?
PM&R is my specialty. It's physical medicine and rehabilitation. So patients that have lost function, and whether that is due to cancer and cancer treatments, trauma, a progressive or acute neurologic condition like a stroke or a brain injury or spinal cord injury, we try to, again, return that patient to their prior level of function or get as close to it. And it's very much a team approach. I have to really rely on physical, occupational, speech pathology. In some sense, in some areas we pull in, psychology whenever it's needed. And again, we're trying to maximize function. So it's very diverse. We can bend and flex to, the needs around us based on, in this setting, a cancer setting, so.
And also used with the gynecological cancers as well?
Yes.
Dr. Schumann, okay, a patient finishes treatment and they're good to go. So now what?
So when the treatment is finished, it's a situation where we will transition into what we call survivorship. a program where we have surveillance, the patient will be monitored closely for any signs of the disease coming back. And the monitoring could be as simple as a face-to-face visit and a physical exam. It doesn't need always labs and imaging, but it could also sometimes require a lab, a blood test, or a CT scan to try to detect those recurrences and to treat them if they do recur. Every cancer have a different schedule. Sometimes we have to see the patient every 3 months, sometimes every 6 months, sometimes on a yearly basis. We educate our patients about what to look for, because the best person to detect the recurrence is usually the patient, not the physician. And if they know what to look for and what are the symptoms that could be associated with recurrence, then they will be able to alert us so that we can investigate that in proper time. In general, it involves a visit, a physical exam, sometimes some labs, and occasionally a scan if we suspect something.
I know that, once they ring the bell or they're finished and they walk out, a lot of times patients and their families, or their families mostly, will, oh, everything's good now, we can move on. So survivorship and that back to normal, now what? That's where they're at. How can patients cope with the constant fear of reoccurrence after all their treatments are finished? I'm going to direct that to you, Dr. Brown. You get all the fun questions.
Well, and I think they have been so wonderfully taken care of by their medical world that they feel very lost without it. I mean, they have gotten used to having people there that if they're nervous, they answer their question. They've had a lot of attention. There's a sense of safety that you would catch something. So when they are into, there's no appointments on my books, they get a little like, first they're excited kind of, but they kind of go through a period of time of where's my tribe? And if it's gone on for a while, some other people, depending on all that group of support you had at the beginning, well, if this has gone on for a while, they've kind of gone on about their world a little bit, and the people that know them best and that they feel the closest to, again, are like shoving them out of a nest. They're like, no, that's fine, I'll stay here. So they come with kind of a sense of, well, now what? And then how do I cope with the sense that now I know that I've had it and it's going to come and get me. I mean, it's really like they're living with the monster in the closet, and one of the things is they can't be blindsided again. The first time you have cancer, you're just totally blindsided, and every single thing is new. Who to go to, who to talk to, what's next. So I do kind of share with them that they can't be blindsided again. You can't control if you're going to get it again, but you already have learned some skills that you will have for if and or when it comes again. And that kind of reassuring them that this kind of lost feeling is pretty normal. They've been being kind of specially treated sometimes by family members too, who are really ready for them to get back into their regular roles. There's a body image issue that is part of the reoccurrence. It's now I may look different. I may have had some surgery. I may feel different. And so who they feel they are, body-wise and mentally-wise, they have shifted. They aren't where they were. And then we look at, well, how do you feel about people touching you or seeing you? It can really get into the family if whether or not people think you're fragile, and then after a while they don't think you're fragile, but you're still really tired. There's a time period to build back up, which is what we're talking about, and you take the personalities that may not have been really good athletes or sports minded or exercise minded or health minded before, And sometimes they become very much that way, so they're afraid of everything they're going to eat that's going to cause something. So they're measuring and talking, or they just, they get tired of the exercise and everybody else is trying to get them to do things to keep it from reoccurring. I mean, there's a whole lot of focus in this time about what can I do? Well, you can't do anything. You have to figure out your coping skill for what is your philosophy. I mean, we get very into what's now your philosophy of life. Control is an illusion. It's very humbling to discover that we really don't have control over things, and that you kind of have to develop a philosophy of how do you handle that. But the main thing I see in the recurrent stage right away is now what they just feel so vulnerable, and they kind of notice that everybody else has gone on. So the medical team has gone on, their family's gone on, and they're kind of here in the middle. And so oftentimes that's where I feel like I can support them the most while they're transitioning back and feeling less fragile emotionally while they're getting stronger physically.
So along with that question, the other taboo topic that no one likes to talk about, especially after going through a cancer treatment, during survivorship, it's really hard to get back to that new normal and figure out your emotional and physical intimacy. That might have changed, especially with these types of cancers. So what can those survivors do, or where can they go to find that empowerment, that information? Because it's not something that they want to, you pick up the phone and you call your friend, or you text your friend on a Friday night and you go, hey. So what is something they can do, or where can they go to find that?
To find where to talk to someone and
talk to someone about that, or how to cope with that, or in ways to deal with that, maybe with their partner.
Okay. Well,
you did mention the body image. Sorry.
Yeah, that's all right. That's a big deal. I mean, a lot of times they don't really want to get close to anyone because they do feel that they are different and look different, and they almost are afraid of kind of a physical intimacy, and oftentimes the emotional intimacy has become fragile. Your caregiver is worn out, and they may have slipped into their old patterns. Whatever your relationship was before, this is a really good time to get connected, but a lot of times they don't. They kind of are like, they don't know whether or not they want to go to bed at the same time, so without in this setting and embarrassing anyone. I mean, it is something that in an office setting such as my own, that's where you can talk about the frailties of your relationship. What I would take and apply to most people is that there is a comfort in knowing that you're not in this alone. And so there's an emotional intimacy that I will spend time with. See, what is in your partner that makes you feel good? The partner may have decided you were so fragile they started sleeping in another room so they wouldn't bother you. Well, that may, by the time this person is recovering, they don't want that person over there. How do you get back in the same room? How do you trust that person? What if they disappointed you? What if they hurt your feelings? So in a setting, a lot of people can do this with their good friends or their family members. But if they want to keep it away from everyone, then in my office, actually, I think they discuss it with physicians, but I just have more time. But that's where you really get down into the dynamics of that there are lots of ways to be close. There are lots of ways to feel intimate. There isn't just one way. I think that getting to feel comfortable with someone that loves you and wants to be with you, you get that foundation, and they can figure everything else out. But if you're not feeling lovable, because if you thought the impact had to do with how close you were, or how much you had sex or didn't, or whether or not you feel attractive, it comes down to how you feel about yourself. So again, we're looking at you and your feelings, and then sometimes we'll bring in their partner if they feel like that would help, because sometimes our fears keep us away from one another, and it's who can bridge that gap first. So that's, I guess long-winded answer to that would be a safe topic in a therapist's office, and kind of guiding them back to just being comfortable being next to someone. The bed is kind of a nice warm nest, and if you're in there too much by yourself, you feel vulnerable, and you feel kind of alone. And so something as simple as going to bed at the same time can change a real dynamic in a recovery, because everything has been off. Your sleep schedule's been off, your fatigue level's been off, and getting back to a schedule of, if you can, unless you're working shifts and all these other reasons. But we figure out things like that on an individual basis.
And I might add also, in addition to the emotional component and psychological component of getting back to intimacy, there's a women's health physical therapy field where we talk about pelvic health and wellness, and a lot of times we talk about function, sexual dysfunction, and returning back to intimacy again. So there are resources in the psychological aspect of care, but also in the physical aspect of care again. So we will often include that topic as part of our questions when we do the intake, but I will let patients bring that topic up if they're comfortable in my clinic.
Thank you for adding to that. And speaking of bedtimes, I could ask you guys questions all night long. I'm sure we could all hang out with you, but for sake of time, we're gonna look at our chat here and see what questions we have. Oh, that's a good question. This is from Debbie. At what point is a patient considered in remission or cancer-free when having cancer with a high reoccurrence rate?
I'll take that question. So remission is when there is no evidence of the cancer by any detection modality. That detection modality could be a scan, an imaging study, a CT scan, a PET scan, or a lab work if the cancer has a tumor marker that you can detect. If you do not see any evidence of the disease in any modality possible, then you can consider the patient to be in remission. Now, remission doesn't mean cure from the cancer. It means that we cannot detect the cancer. Cure is dependent on, obviously, the type of cancer, the stage, and how long has the patient been in remission. We, in general, in oncology, a patient that gets treated and is in remission for 5 years or more, they might be considered to be cured of the disease. But we take that very cautiously because there are some cancers that can recur after that. And but the odds become very little and very small, and that we can safely talk about a cure in that situation.